There were a number of, based on our internal discussions and the feedback that we got from people, a number of potential weaknesses with the existing HCR-20 version 2 that we were going to try to address. So one of those is overbreadth of item content. Some of the items we felt maybe tried to capture a little bit too much. So for example, H8 and C2, early maladjustment, negative attitudes, there was a lot of information, a lot of content domain covered within these items. So what did we do? I'm just going to give you some examples of how we dealt with these things. We split some items up. So H8, in fact, we narrowed this to some extent by removing the youth antisocial behavior aspect of that, and we placed that elsewhere. And H8 is now split into two items. It's now called victimization and traumatic experiences. H8A, focusing mainly on things like child abuse and whatnot. H8B, non-abusive but still adverse child rearing experiences. So having a parent who's been convicted of a crime or living in a dangerous, chaotic household or neighborhood. Trauma now, we have content in that item where any trauma across the lifespan will satisfy the requirement of this item, as opposed to just child abuse. We've learned that if a person is victimized as an adult, that in fact elevates their risk for violence. Some items we just narrowed. So with C2, we narrowed it from kind of the broad negative attitudes, which included many things, kind of being a little bit pessimistic about the future generally. We narrowed that really to focus on violent ideation and intent. So it's much more focused on the things that we think are probably more strongly related to violence. Some items we felt were redundant, so H7 and H9, of course, psychopathy and personality disorder. Well, those are two very related concepts. In fact, you could argue that they're the same concept. So we combined those. We now have a single personality disorder item. Again, two sub-items, the first of which is antisocial, psychopathic, or dissocial, and the second is other personality disorders. And as I mentioned, the PCL is no longer required. Some of the items had liberal score thresholds or rating thresholds or restricted range. So previous violence, it was maybe a little bit too easy to score a 2, that's version 2 lingo, or to be rated present, that's version 3 lingo. We've changed that as well. Really didn't permit the capturing of anything beyond a simple past act of violence or a few minor past acts. So with version 3, we tried to write it in a way where it would capture chronicity, violence across the lifespan, and we did that in part by having sub-items for this particular item: violence as a child, as an adolescent, and as an adult. In some areas, the manual just lacked details, so we wanted to attend to that. There was not a lot of information, as I mentioned before, about decision-making steps. How do you make the ratings of low, moderate, high? I'm still asked, as I'm sure others are, what's the cutoff? My patient has a score of 26. Is she high risk? I don't know. Not a lot of information also about the link between, as Steve talked about, the general or the nomothetic level, what we know in general about violence, and how to apply that at the individual or idiographic level. Risk formulation and the facilitation of risk management plans. So we have added a considerable amount of text and discussion of these various different topics. So what was the actual process? So now we came up with a draft. We had a draft version 3 in December of 2008. And we started taking it for a test ride, basically. So there was a conference in December of 2008 in Manchester, which was organized by Mike Doyle and Jenny Shaw of the University of Manchester. A number of folks here I know were there. We had that Manchester meeting where we sought feedback. We also had beta testing done in the Netherlands, in Sweden, and in Germany, and in Norway. The Norwegian feedback came after the first round of feedback, so we could get separate feedback on later draft in the process. It's important to point out that the first draft of version 3 included a couple of features which we've since got rid of. And one was we had a 4-point or level rating system for the items. So we had no, possible, present and extreme. And Steve, Henrik, and Chris didn't like that. I liked it, but I was outvoted. I was voted off the island, right? And in fact, we got feedback that maybe it's not necessary. We also had mandatory rating of indicators. And as it turned out, we had some unclear instructions about how the risk factors, the sub-items work relative to the overarching items. People weren't clear whether you needed to have all of the sub-items rated as present to have a present rating on the overarching risk factor or not. So at this conference, this was a 2-day conference. Day 1, there was a few kind of brief presentations. Day 2 was by invitation, and we invited people who were familiar with, experts with using or researching version 2 of the HCR-20. And we spent a good 4 or 5 hours presenting it. Then people broke into little groups and chatted about it, and they wrote feedback on it, gave us their impressions. The feedback tended to be positive, but nobody had had a chance to use it yet. So people seemed to like the ideas, but we hadn't yet received feedback on the basis of people actually trying to use it. So we asked 3 groups of colleagues at this point to try this first draft out. In the Netherlands, at the Van der Hoeven Clinic, Vivian de Vogel coordinated this beta testing with 10 clinicians, each of whom rated 1 case. And this is the feedback that we got. So they started out very nicely. They said, it seems like a valuable revision. And then they told us what they really thought. They said, it's a major, extended, and complicated version of the HCR-20. It takes more time. It's too long. It's too complicated. People lose motivation. The indicators are useful for guidance. In Sweden, coordinated by Henrik, 5 raters completed 1 or more cases. And in fact, we have a couple of the Swedish clinicians who do the HCR-20 and participated in this work here with us today. Very similar to the Dutch reaction in terms of maybe it's a little bit too complicated. Didn't like the 0, 1, 2, 3 system, the 4-point system. They thought it was redundant with the relevance ratings. They did say it gets easier as you use it, which was good to know. And then finally, the German beta testing. So 15 clinicians in the Heine system. This is organized by Sabine Jucker and Rüdiger Müller-Isberner. Again, a range of experience of the clinicians. They had known and unknown cases, range in diagnoses, range in privilege levels. They did a focus group. They did item-by-item feedback, and then overall feedback. They gave us an executive summary in English. They gave us 21 pages of German, item by item. It was very detailed. It was very organized. And we couldn't read it. Thankfully, one of my PhD students, her boyfriend speaks German. So it was kind of a little subtle pressure, like if you really want that dissertation, maybe ask your boyfriend if he can translate for us. Actually, I wasn't that mean, but he did translate it for us. So we got actually wonderful feedback. Similar to the others, it's too complicated, long, confusing, it's not user-friendly, you can't see the forest through the trees, what's the relevance of relevance? 0, 1, 2, 3 is unnecessary, the indicators are too cumbersome, bring back the PCLR and please don't ruin it. That was the feedback that we got. You know, if you ask people what they think, they'll tell you what they think. But that's exactly what we wanted. So our response, we dropped the 4-point or 4-level system, went back to the familiar 3-level system, yes, possible, no. The rating of the indicators is optional. They're there as guidance. We clarified the rating of the sub-items. If you have any of the sub-items, by definition now, you have the overarching risk factor. We made multiple rating sheets, so for people who are comfortable and familiar with using a 1-page rating sheet, you still can. We have one. We have a 2-page rating sheet that includes the sub-items. And we have the extended worksheet, which includes all of the 7 steps, which Steve reviewed this morning. We made a number of refinements to items, to instructions, and so forth. A couple of sub-drafts, so draft 2, draft 3, we call it when you get the manual. That's how they're referred to in the manual. We talked to our Dutch, Swedish, and German colleagues about this, and they seemed to be happy with the changes. And then we asked our Norwegian colleagues, many of whom are sitting here right now, to give us their impression of it. So they organized the use of version 3 with 20 patients. 2 clinicians rated 10 patients each. And this is just a few quotes from the report which was sent to us in January. They thought it was a step forward to improve risk assessment of violence, permits a more systematic and detailed assessment. Relevance ratings are a major strength that allow a tailor-made and recognizable risk management plan. And this group was also involved in some of the concurrent validity testing, which I'll talk about shortly. So that seemed to give us some sense that we put it through a pretty rigorous process of sending it to colleagues who were experienced. They used us, they told us what they thought, we made some changes, we gave it to more colleagues, they told us what they thought, and we were getting more and more comfortable with the product. I just want to talk about a couple of the features which we've added to just give you a little bit of a preview of what they'll look like in the manual. So we have this idea of item indicators, and as I mentioned, this is intended for guidance. They are bullet points that come underneath the definition of each of the items, and they're more specific ways that the item may manifest. They're intended to help people think about the risk factor at the individual level. So what I'm going to show you next is actually just a screenshot of one page from the manual, which you'll get this afternoon. You don't need to actually be able to read it. What I just want to show you is the layout. Okay? That's the definition. These are the indicators. And then there's coding notes underneath. This, you can use this to make the rating of no, possible, or yes. And you can refer to the indicators. So you can make the rating based on the general definition. History of problems with violent attitudes, that's the new H9. The risk factor, which can also be thought of attitudes supportive of violence, reflects a history of entrenched violent attitudes, beliefs, values, or thoughts, and so on. You can make that judgment of the presence of the item based on that general definition. But if you want to start thinking about it more specifically, well, what does it really look like for my offender, my client, my patient? We've provided indicators. So was it present during childhood or adolescence? Has it been present across different developmental periods? Have people often thought, fantasize, or daydream about violence? Are they mocking or belittling others? Has it got worse over time? Has it been present in the recent past? So these are just ways to think about, well, what might this look like for my person who I'm sitting here working with? You don't need to rate these, but they're probably worth thinking about. In terms of relevance now, Steve had talked about relevance, so this is how we define it in the version 3 manual. And for those of you who are staying for the workshops after, you'll be getting a lot of opportunity to be working with this concept. So risk factor is relevant if it was a material contribution to past violence, it's likely to influence a person's decision to act violently, it impairs their ability to employ nonviolent problem solving, or it's necessary to manage to prevent violence. So this brings us from thinking about just is the risk factor present, but also whether it's relevant. And in tandem with item manifestation, we hope that that helps people get a good, full understanding of what the risk factors actually look like in detail for the people that they're working with. Okay, so a little bit about the risk factors now. We have the historical scale, of course, whether the risk factor was present at any time in a person's life. These are not intended to be static we think, we made a mistake in version 2 manual. We actually called the H scale factors static. And a lot of them, of course, can change. Substance use problems can change. Major mental disorder is inherently dynamic. These are historical, so once you've had a major mental illness, you will always have had a major mental illness. But now we encourage people to think about how these risk factors have changed over time and what they look like currently. So I'm just going to give you the titles of each of these risk factors, point out where there's a couple of differences. So H1, and the way that we've titled the H scale now is every item has the prefix, a history of problems with. So now H1 is a history of problems with violence. 3 sub-items, child, adolescent, adulthood. A new item, H2, is no longer young age at first violence because we can now capture that under H1A, right? H2 now is other antisocial behavior. We didn't really have a good place for that on version 2. If it happened when a person was young, you could capture it under H8. But if somebody was out committing nonviolent crimes as an adult, we didn't really have a good place to capture that. H3, this one we've actually broadened. So of course H3 with version 2 is just intimate relationships. Now we've added another sub-item for non-intimate personal relationships. So if you're having problems with friends, with family members. H4 stays pretty much the same, as does H5, substance use problems. H6 is now split into 3 sub-items. The overall or overarching meaning of this risk factor is not terribly different. But we thought for greater clarity, we would specify the different domains of disorders that we were interested in. We actually had to spend a little bit of time recently making this kind of DSM-5 compliant. The DSM-5 folks are putting out their manual next month, and they've released their table of contents, so we just wanted to make sure we use the proper terminology. The other major mental disorder category here, these are neurocognitive, intellectual disability disorders, and there's a wide array of these that are in DSM-5. H7 I had talked about already. Personality disorder. H8 I'd also mentioned already, so a history of problems with traumatic experiences, 2 sub-items. H9 I'd given you the example. This is another new item. We had, and in the coding notes to this item, we recommend that people also think about whether a person's had antisocial peers and whether that's reflective of antisocial attitudes or violent attitudes. We wanted to draw in or draw upon the vast criminological correctional literature, risk need responsivity literature, where violent antisocial attitudes, antisocial peers are amongst the most important risk factors identified for them. So now we've tried to incorporate some of that into the HCR-20. And then H10, there's a name change, but treatment or supervision response in the past. The clinical scale. So we've added a little bit more information about how far back you should be looking. And in general, Steve had mentioned, I think, 1 to 6 months. I'm saying 6 to 12, and in the manual we say 1 to 12. So we agree, ultimately. In general, about 6 months. Sometimes it makes sense if somebody, for example, you've been working with for years and years and years has been stable, you might want to only see them once a year. You might need to only update it once a year, so you'd be looking back about 12 months. Somebody who's very high risk or somebody who's brand new to you, you might be looking back only a month or so. So you can't give a specific interval here, but somewhere within the last 12 months, with 6 months probably being a good average marker. We also provide more information about how often the C-scale should be reevaluated. We didn't really talk about that in version 2. So there's some information about how it should be tied somewhat to a person's risk level. If somebody's higher risk, you probably need to reevaluate more often, obviously before any important security-related decision, if there's been any changes in functioning, or if there's been any recent violence. So Each of the C items starts with the prefix of recent problems with. And insight, same general meaning, but we've broken that down into the 3 categories that ultimately were captured by that item, but we think sometimes got lost. So insight into mental disorder, violence proneness, and need for treatment. I'd mentioned to you that C2 has been narrowed, so this is violent ideation or intent. C3 is really, of course, the current analog of H6. C4 was impulsivity. We've changed the name to instability. In the first version of the HCR-20 in 1995, it was instability. We changed it to impulsivity. We don't really remember why, but now we're going back to instability. And then finally, C5, we split into both compliance and responsiveness. So you see, actually, the content is not terribly different. A little bit of narrowing here, a little bit of expansion there, some sub-items. But if you use version 3 and you're already familiar with version 2, you should get to a point where you're feeling comfortable fairly quickly, particularly if you've also been familiar with other SPJ instruments and you've been following the literature. Okay, the risk management scale. We have more information about providing guidance about how far into the future people should be looking. And again, we'd say about the next 6 to 12 months in general. And this should coincide with the reassessment interval. So if you are seeing somebody every 6 months, well, then maybe it makes sense to be making these ratings on the basis of the next 6 months. As Steve mentioned, we still retain the institutional and community rating system. Each of the items starts with the prefix future problems with. So future problems with professional services and plans. And as you know, the current R1 is plans lack feasibility. We liked that item, but it tended to really throw everything into it. So there was a lot of overlap with the other R items. One of the things that we tried to do with the R scale was make each of the items a bit more of a standalone item. R2 is now called living situation. So we're interested in whether in the institution or in the community, the degree to which a person's living situation would either facilitate the plans being successful or may destabilize a person. R3, personal support, hasn't changed too much. Treatment or supervision response, we've just added the sub-items, both compliance and responsiveness, and stress and coping hasn't changed too terribly much. The final opinions is the last stage. Steve had mentioned this part as well. This is the form that we've put together to capture those final opinions, just so that you kind of get a little bit of a sense of how you'd be able to do so. So let's move on to the empirical evaluation. We thought it was important because the HCR-20 has been used so broadly across 35 different countries, 200 studies, et cetera, we needed to show that our version 3 draft and that the final product of version 3 should work about the same as version 2, so that when you use it, you feel like you can rely on it. So we had 8 samples. When I say we had, what I mean is we asked other people to gather a whole bunch of data, and they were very nice, and they did. So I have 8 samples which I'm able to share with you. So 5 of these were within forensic settings, 1 civil psychiatric, and 2 correctional settings across 6 countries: Canada, the Netherlands, Sweden, Norway, the United Kingdom, England and Wales. I'm sure there'll be a Scottish one coming soon, and the United States. And in total, 782 participants. So this is actually not too bad. And there's a number of these studies are actually still in progress, and there are a few others that are underway. So for reliability, 4 different samples have looked at reliability, and you just have the total N at the bottom to tell you, when I show you the summaries of reliability and concurrent validity, et cetera, what sample size is that based on. You can see there's 6 different studies that have looked at concurrent validity and 3 that looked at predictive validity. And based on over 500 people. So looking at concurrent validity, you can see this is the correlation between version 2 and version 3. And when I had mentioned that we didn't want to change it too terribly much, you find that for the total, the H, the C, and the R scales, this is the median correlation across those 6 different studies, okay? So here's the ranges. The median correlations are all 0.7s to 0.8s. So that's quite a high correlation between the versions. And with the summary risk ratings, in fact, it was really very high. Study that Henrik and I did based on 35 patients, and a lot of the cases were rated by Lars Henrik and Mats from the Sundsvall Hospital who are here. 3 raters of each patient, interview and file review, both version 2 and 3 were done. Questions were inter-rater reliability and concurrent validity. I'll just show you the inter-rater reliability here. So I'll just draw your attention to this category. So for H, the C, the in R and out R ratings, and then the total scales and the final judgments. All of these ratings are acceptable. Many of them are really quite high. So for the total score, inter-rater reliability in the 0.9s, same for the H, a little bit lower for the R scale, still respectable though, and for the final judgments, also still quite respectable. I'll tell you a little bit about a study that some of our Dutch colleagues carried out based on 86 patients. They did a retrospective follow-up for 3 years. They looked at version 2 and version 3 as well as the SAPROF, again, inter-rater reliability, concurrent validity, and predictive validity. So I'll just tell you about a couple of their findings. Inter-rater reliability, again, was quite strong here. In terms of predictive validity, really what to look at here is HCR-20-V3. These are AUC values compared to version 2. And you can see basically across the different follow-up periods that they're really quite comparable. Mike Doyle and colleagues in the UK followed up 387 patients. This was 12 months unselected cohort of patients who were discharged. File plus interview, prospective, so really quite nice design here. They had both a 6 and a 12-month follow-up. Inter-rater reliability for the total sum of the presence ratings was 0.73. And focusing on those presence ratings, the AUC values were 0.7, 0.73, depending on whether it was a 6 or 12-month follow-up. So again, that's respectable. It's right on par with the meta-analytic findings that I presented earlier. In a regression analysis, the HCR-20 version 3 was significant even after age and gender had been controlled. The last study I'll tell you about was based on some work that we've done in Vancouver, 106 civil psychiatric patients and offenders, so kind of 2 subsamples. Again, file plus interview, prospective. We had both a really short-term follow-up, 4 to 6 weeks in the community after discharge, and 6 to 8 months, so kind of a moderate-term follow-up as well. This, we focused on the summary risk rating. So what I'm going to show you is how well those judgments of low, moderate, or high did, both at 4 to 6 weeks and 6 to 8 months. So I have both correlations here, for those of you who like correlations, and AUC values here. And you can see that at 4 to 6 weeks, there's quite a robust association between the judgments of low, moderate, high risk and violence, 4 to 6 weeks later. This is in the combined sample. Similarly, at 6 to 8 months, again, a robust association. Just looking within the psychiatric subsample, about half of the 106, again, correlations about 0.5 and AUC values 0.74 to 0.91. Again, these are quite robust. And in the correctional sample, correlations a little bit lower, but still in the moderate effect size range, both at the 4 to 6 weeks and 6 to 8 month time frame. And even though there was a little bit of variability between psychiatric sample and the offender sample, In fact, those didn't differ significantly, so they weren't moderated by sample or by gender. And just to show you the proportion of people who were violent in the low, moderate, and high categories, so this is at 4 to 6 weeks. You can see it's only 2%. In fact, that was 1 of 46 people who were violent in the next 4 to 6 weeks. About 16% in the moderate risk judgment group, and about 45% in the high risk judgment group. And again, at 6 to 8 months, now it's about 15% of the low risk group, 36% of the moderate risk group, and 67% of the high risk group. So does that mean that when you say high risk, there's a 67% probability that someone's going to be violent? No. Does that mean that you can have some confidence in your judgment if you use this system? Yes. And that's really why we do this type of research, is just to try to demonstrate that if you use this system in the way that we recommend, you can have some confidence that your judgments are actually related to violence in the way that you are representing them to be. So to just kind of conclude, we do have a strong association between version 2 and version 3. Reliability is looking primarily strong. There's a good basis so far for the association between the risk factors, at least if you look at them all together, summed up, and future violence, as well as for the summary risk ratings and future violence. I think in the last couple minutes, I just want to wrap up by providing a couple of recommendations for evaluating version 3. So, of course, it'll be important to look at the inter-rater reliability, the predictive validity, as well as the dynamic change in the presence, relevance, and summary risk ratings. Also looking at the incremental validity of each of those over the other. So do the summary risk ratings improve upon the presence ratings and so forth. In terms of indicators, this is a bit tricky because we're not intending them as kind of psychological tests. So it may not make sense to be looking at whether, if you add up all the indicators, or those related to violence. But certainly there could be some benefit or value in looking at, for example, whether people use or don't use the indicators. Does that help them in terms of developing management plans, risk management plans? And for research purposes, it could be okay to look at their association with violence as well. I think it would be fascinating if you look at the next 2 bullets, formulation and scenario planning, to try to evaluate those. So if people arrive at certain formulations, does that help improve management plans? Does that help to reduce violence? Are they correct in the formulations? Are they correct in the scenarios? Really hard to test, right? Because the whole purpose of doing it is to try to put plans in a place to reduce it. So you'd have to try to devise some clever way to maybe do it after the fact, or to look at whether the use of them actually reduces violence, right? Risk management, are we able to, by using version 3, increase the quality of risk management plans? That is, are there more services and plans put into place that link up with the relevant risk factors that have been identified? And in terms of implementation, I mean, there's a number of examples, many of which are represented by people sitting in this room, of really successful implementation of the HCR-20 at a hospital-wide level or system-wide level. There hasn't really been a lot, though, of systematic study, even really case studies published of successful implementations. Henrik is going to talk about that after lunch. But I think that this could be a really good opportunity for a lot of the people who are planning to implement version 3, and there's quite a few groups of people who want to do that, to try to bring some formality to at least the way that that is described and maybe communicated to the rest of us. Cross-cutting topics, of course, it will always be important to look at the performance of all of these topics across gender, across ethnicity, across country and setting and so forth, and that is what we would certainly recommend as well. So with that, I hear some stomachs grumbling. I will thank you for your time.